all. So today we are here for the IMA AMS webinar, which is conducted on account of World Health Day 2023. So because we had many programs on that day, today we have organized this webinar. So the topic is health for all. What does it mean? Is it a realistic goal? So for this webinar, I would like to welcome our state president, Dr. Lakul sir. We wholeheartedly welcome you, Dr. Shiv Kumar Lakul sir, for our webinar.
Namaskar. Namaskar.
I welcome our past president, Dr. Madhusudan Kariganur sir, for this webinar. We welcome you, Madhusudan sir. I welcome our IMA AMS headquarters, a chairperson, Dr. Pankaj Mutneja sir, who has joined us in spite of his busy schedule. We wholeheartedly welcome you, sir.
Thank you. Thank you.
We welcome Dr. Srirang sir, who is the honorary secretary of IMA AMS headquarters. We wholeheartedly welcome you, sir. We welcome the honorary secretary of IMA Karnataka State Branch, Dr. Karunakar sir. We wholeheartedly welcome you, sir.
Thank you, madam. Thank you so much.
We welcome the vice president of IMA Karnataka State Branch, Dr. Rajeshri Anugod madam. We welcome you, madam.
Thank you, ma'am. Thank you. Thank you very much.
Yes. I welcome each and everyone who has joined us for this webinar. And I welcome the speaker of today, Dr. Annarao Kulkarni sir, who has readily accepted to give the talk on account of our webinar. We wholeheartedly welcome you, Dr. Kulkarni sir, on behalf of IMA KSB and IMA AMS.
Thank you. Thank you.
Now, I request Dr. Karunakar sir, Honorary Secretary, IMA Karnataka State Branch, to deliver the IMA prayer and flag salutation.
Thank you, madam. Actually, good evening, everybody. It's been an honor to, as a secretary, to do the honors of reciting IMA prayer, actually, and with the permission of our beloved president and every one of you attending today. I take this opportunity to, just a moment, I'm just checking. Yeah, I take this opportunity to start with IMA prayer. That's our kind of Bible to start up our work. I'm starting now. Bharatiya Vaidyakiya Sanghada Prarthane. Ellaru Santoshavagirali. Ellaru Arogyavagirali. Ellaru Novininda Muktavagirali. Ellaru Dukkadinda Muktavagirali. Ella Ase Amshigalannu Meeri Gunapadiಸುವವರು ನಾವಾಗಿದ್ದೀವಿ. Jai Hind, IMA Chureyavad. Thank you so much. Madam, it's back to you. Thank you so much.
Thank you, sir. I request Dr. Lakul sir, President IMA Karnataka State Branch, to say a few words on this occasion.
Okay. Can you hear me, madam?
Yes, sir.
Good evening to all. Today, IMA KSB and AMS conducting a webinar on account of World Health Day. In Karnataka, all over the nation, you have conducted many activities celebrating World Health Day in almost all the branches of Karnataka, and also in national wide. They have conducted activities like marathon, cyclothon, and sports activities and awareness programs all over the state and also country. In this connection, today we have got a topic on health for all. What does it mean? And is it a realistic goal? Very, very important slogan today we are having to discuss this. We have got a very good speaker like Dr. Annarao Kulkarni, Professor and HOD of P&SM, Bangalore, and also National President-elect IAPSM. And the very renowned person and also the chairman of AMS headquarters, Dr. Pankaj Mutneja, is chairing this session. And also we have got Sri Ranga from headquarters. And I really heartily welcome all the members, including the speakers and also the guests of headquarters. And today we have got our Secretary Karunakaran sir, and also President-elect Srinivas, and also past President Dr. Madhusudan Kariganur, and Vice President of KSB Rajeshri Anugod madam, and also chairperson of AMS, Dr. Geeta Dappa Madam, and all the esteemed members of AMA KSP. Really, we have got a very good speaker and also chairperson. Without taking much time, I hand over the mic to Geeta Dappa Madam to proceed.
Thank you, sir.
Thank you.
So now I would just like to introduce our chairperson of today and our speaker of today, and then I will hand over the program to our program chairperson. So Dr. Pankaj Mutneja sir, he is an accomplished general surgeon with over 27 years of experience with special interest in urology, leverages exemplary management skills and owns a 240-bedded groups of super specialty hospital, LHDM and Dr. Prem Hospital. Sir is the head of the Department of Surgery at LHDM and Dr. Prem Hospital since 1st of July 1991 till date. He is an active life member of Associations of Surgeons of India, active member of Urological Society of India, member of Critical Care Association of India. Sir has established the Trauma Center at LHDM Hospital. He is a lecturer in PIMS for surgery since 2006 till now. It involves lectures in surgeries to undergraduates and postgraduates of nursing and physiotherapy courses. Sir has introduced quality procedures in Department of Surgery, Operation Theatre at LHDM and Dr. Prem Hospital, which is accredited with NABH. Sir was elected as IMA President of the state of Haryana in 2016, and he has established the Oncology Department as a part of Surgery Department in 2017. Special mention is the paper which has awarded the best paper conference in North Zone Surgical Conference at Ludhiana, which was a distally based faciocutaneous flap for soft tissue defects of lower two-thirds of the leg. Sir was elected Vice President of Haryana Medical Council in 2019. Sir represented North Zone IMA HBI for pre-accreditation entry-level NABH certification. Currently, Sir is the Medical Ethics Core Committee leader. Sir heads the 240-bedded group of hospital, NABH accredited super specialty, LHDM and Dr. Prem Hospital since last 10 years. There are many core competencies like Sir is interested in strategic planning, resource allocation, team leadership, operational excellence, competitive intelligence, and so on. And really, we are indeed lucky to have you, sir, as the chairperson of today's webinar. We wholeheartedly welcome you, sir.
Thank you.
A few words about our speaker for today. Even sir's CV is so big, but I have really concised it. So the speaker for today is Dr. Anna Rao Kulkarni. He is the National President-elect of IAPSM, EC member of National IAPSM 2013-14, 14-15. And he is the President of IAPSM Karnataka State Chapter since last 6 years. Presently, he is the Professor and Head, Department of Community Medicine, East Point College of Medical Sciences and Research, Bangalore. Native of Gulbarga, he did his MBBS from KMC Hubli, DPH from and MDPSM from LTM Medical College, Mumbai, DHA from Tata Institute of Social Sciences, Mumbai. He has done a diploma in yoga therapy, teaching experience of around 32 years in Mumbai and Karnataka, worked as primary healthcare specialist in Saudi Arabia for 11 years. He worked for 1 year in Libya, established urban health centers in Shivaji Nagar and Dharavi in Mumbai, worked with WHO as SMO in National Polio Surveillance Project in Pilibhit, and he is a qualified and trained Bhagavad Gita teacher too. So let us start today's webinar with Dr. Pankaj Mutneja sir chairing the session and Dr. Kulkarni sir, who will be talking on the topic Health for All. What does it mean is it a realistic goal? Over to you, Dr. Pankaj Mutneja, sir, to conduct the program. Thank you.
Thank you, Dr. Geeta, for such a elaborate line, especially our president, Dr. Lakol, IMA President and Secretary, Dr. Kanunkara, Dr. Geeta, Chairman, IMA MS, Dr. Suresh Kagalkar, and very many senior on this very exciting topic. Why I say exciting? Firstly, we have a very reputed speaker, Dr. Anna Rao Kulkarni, a very, very accomplished community medicine person. You know, why I say it was interesting, ever since I joined medical college in 1979, we've been hearing the health for all in the Alma Ata Declaration. And today, 45 years later, I don't know if we have even touched it in any way. So I always used to wonder, did somebody make a typo error? Because those were the days of typewriters. So rather than health for all, it should have been health care for all, which would have been an easier goal to achieve. So certainly when Sir talks of, is it a realistic goal? We are excited to take his viewpoint. And now I'll request Dr. Anna Rao Kulkarni to please go ahead with this topic which we have been hearing again and again, health for all, and where have we actually reached? Thank you. Please, Ken.
Thank you very much, sir. Dr. Pankaj Mutneja, sir, for your kind words. At the outset, let me thank IMA Karnataka State Branch and AMS for giving me this opportunity. Without wasting much of the time, let me start with the topic. Can you see my slide, please?
Yes, sir. Yes, sir.
Yeah, and you can hear me also clearly?
Yes, sir. Yes, sir.
Yes,
Okay.
just,
Sir, besides, sir, not that one. Just
sir,
besides.
you do
slide.
slide share, sir.
Yeah, I'm doing just. I'm
Slide
trying
show.
to do.
Yes.
Yes. Is it clear now?
Yes, sir. Yes, sir.
Yes. The topic that I have selected is health for all. This is the theme of WHO Day 2023. And I want to talk about what does it really mean and is it a realistic goal? Because just now Dr. Pankaj sir said that he has heard 45 years back. Yes, even I have gone through this. I had just passed my MD, and that time this slogan was there, health for all by 2000 AD. Still, we are nowhere near it, rightly said. So we will understand little more about this topic today. So 7th April, first let's understand about the World Health Day. 7th April, we celebrate every year World Health Day because on that day, the constitution of the WHO came into force. Okay, that is on 1948. But from 1950 onwards, every 7th April, we celebrate World Health Day. On this particular day, WHO formulates or gives us one slogan, which is of national, local, or international importance. So we have to focus on that, and the whole world has to work towards achieving that goal. So this is the picture depicting 75 years of achievement of WHO in health for all, but we were not able to achieve this. Therefore, this is a repeat slogan, health for all this year. Now, I heard the Karnataka state IMA prayer, very much it is health for all, nothing else other than health for only. Here also you see, we hear this prayer every now and then, Sarve bhavantu sukhinaha, sarve santu niramayaha, sarve bhadrani pashyantu, ma kaschid dukkha bhag bhavet. So this is nothing but a prayer for health for all. Our ancestors were healthy. Okay, they were having health, okay, all of them in fact, and they were praying for health for all, okay, all the time. So this is not new. Health and health for all did not come with WHO. Health was there, okay, particularly in our country. Even when the Westerners were not civilized, we had a civilization much older than that, and our health, our ancestors' health particularly, was much, much better when compared to others. But unfortunately, because of so many factors, we lost track of our culture, traditions, and therefore we have lost our health also. This is another thing. In Atharva Veda also, there is evidence of health for all. Pashyema Sharadashatam, Jivema Sharadashatam, Buddhema Sharadashatam, Rohema Sharadashatam, Pushema Sharadashatam, Bhavema Sharadashatam, Bhuyema Sharadashatam, Bhuyasi Sharadashatam, Shatat. So this means, okay, 100 years I have to see that. For that, I have to live for 100 years. For that, my intellect has to be intact, so on and so forth. And that means people who are living 100 years, and that is how we have got, okay, four, in a man's life, the 100 years are divided into 4 stages. So 100 years was not at all a problem for longevity in our ancestors. But now, when I was born, 1955, the expectation of life was only 35 years. Okay, so there is lot of improvement in the health in the Indian conditions also, but still there is a very long way to go.
Hello, man. How are you?
Can you hear me?
Anji.
Yes, sir.
Yeah,
Yes, sir.
okay. Yeah. Okay. So when we are saying health for all of us know this definition of health. Just for completion's sake, I will take this because this is what we want for all. So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, that enables a person to lead a socially and economically productive life. This is what is the health that we want for all. Okay, is it possible? Is it feasible? Is it realistic? That's what we will see. Okay, exactly what does it mean? Globally, there has been in recent years some improvement in the world's health. Yet, a newborn child in some African countries has only 50-50 chance of surviving through adolescence. 4/5 of the world's population have no access to any permanent form of healthcare, and only 1 in 3 persons in developing countries has a reasonable access to safe water and adequate sanitation. So in this condition, okay, is it possible to achieve health for all the way we want it to? Health for all means that health is to be brought within reach of everyone in a given country, and by health is meant a personal state of well-being, not just the availability of health services, a state of health that enables a person to lead a socially and economically productive life. Health for all implies the removal of obstacles to health, such as malnutrition, ignorance, contaminated drinking water, and unhygienic housing conditions, quite as much as it does mean the solution of purely medical problems, such as providing doctors, hospital beds, drugs, vaccines, etc. So health for all means that health should be regarded as an objective of economic development and not merely as one of the means of attaining that economic development. So it has to be central to all our activities, all our programs, all our policies. Health for all depends on continued progress in medical care and public health. Public health is more important. Medical care is okay. Medical care cannot give health. Okay. Public health definitely is more important than medical care. The health services must be accessible to all through primary health care, in which the basic medical help is available in every village, backed by appropriate referral services to more specialized care. What is our understanding of primary health care is whatever is available in the sub-centers and primary health centers, that is enough. Okay, I'm in the hospital, I'm not concerned with primary health care. No, the definition of primary health care is essential health care made universally accessible and acceptable, okay, using appropriate technology at the cost that the country and the community can afford. This is the definition. So essential healthcare, if a person requires an emergency surgery, that is primary healthcare, because that is what is essential for that person. So essential healthcare, primary healthcare doesn't mean only in the primary health center. Every hospital, every institution, every healthcare provider has to be linked to primary healthcare through appropriate linkages. Health for all is thus a holistic concept calling for efforts in agriculture, industry, education, housing, and communications, just as much as in the medicine and public health. Because we know, we will come to those determinants a little later, health is determined by so many factors which are beyond the control of the healthcare services or the medical professionals. So unless those factors are also taken into consideration, also those factors are improved, health cannot be improved. Health for all cannot be achieved. That is why we were not able to achieve health for all in the first place when it was declared in Alma Ata. Medical care alone cannot bring health to hungry people living in hovels. Health for such people requires a whole new way of life and fresh opportunities to provide themselves with a higher standard of living. So standard of living is very, very important. Poverty is a root cause of all ill health. Okay, therefore, unless we tackle poverty along with providing medical care, health cannot be achieved. So why did health for all fail? Before that, I will come to this. Health for all simply means it is a responsibility of individual, the family, the community, and the nation as a whole or the whole world. So for that, starting from the individual, we must all be responsible for our own health. So I do anything and everything and blame the health department or health system for my ill health. That's not acceptable. So what an individual should do for remaining healthy? If everybody remains healthy, takes care of himself or herself, then everybody, that whole world becomes healthy. So for this, you must simply have a balanced diet, 6 to 8 hours of sleep, physical activity, regular bowel and bladder movements, moderation in all spheres of life, and at least 100 grams of fruits, 500 grams of vegetables, 200 liters of water per day, and 30 to 45 minutes of walking every day, at least 5 days in a week. Okay, are we doing these things as doctors? We will ask ourselves. Okay, I am sure many of us are not taking 500 grams of vegetables and 100 grams of fruit on a daily basis. We are not doing this regular activity, physical activity for 35 to 45 minutes every day. So when we are not able to take care of our own health, how can we take care of the health of the entire population? So we have to understand that health for all begins with the individual, family, community, and the country. So these are the determinants of health. Unless we understand what determines health, we will not be able to provide that. So we have to understand the determinants of health. It starts with the individual, then comes to the families, then the communities, and then the society or the whole country. So everybody has to take responsibility and do their part of work. Unless this happens, health for all cannot be achieved. Now we have got biological determinants, behavioral determinants, environmental determinants, socio-economic determinants, health systems, socio-cultural. Socio-economic and socio-cultural are different. Traditions, customs, beliefs. Okay, these are socio-cultural determinants. Aging of the population, science and technology, information and communication, gender, equity and social justice, and human rights. So many determinants are there, and only focusing on health and healthcare delivery will not improve health, okay, will not provide health for all. That's why we were not able to achieve health for all in the first place. I'll come to that a little later. Okay, now these are social determinants, very, very important, okay, much more important than the medical factors. The social determinants are called as root causes of all health problems. Unless we understand this, unless we tackle them, health cannot be achieved for all in the way we want them we want the health. So in the first place, why did health for all by 2000 fail? Just it was mentioned by your president. So we will just understand some of the reasons why. There are many reasons, but we will understand at least some of the important reasons why health for all failed. One of the reasons for the failure of health for all by 2000 was a lack of conviction and commitment from several countries, particularly those aligned with the USA. Since the Alma Ata Declaration announcing health for all by 2000 came from erstwhile USSR, the suspected the idea was a communist Soviet policy to introduce socialized medicine. So they were deadly against the Cold War at its peak. So they were deadly against the Soviet Union, and therefore particularly the America, the United Kingdom, and the Western countries, they did not do much for achieving this health for all. The lack of new economic order to address inequities which determine access to nutrition, safe drinking water, and sanitation led to no improvement in the health. These in turn reflect on the health of a population as adequate policies were not framed to address these issues. The reliance on primary health care, on community health workers. The primary health care, as we all understand, is mainly delivered by non-medical workers, or basic healthcare workers, primary healthcare workers, ASHAs, Anganwadis, multipurpose workers. So this meant that promoting inexpensive interventions made it look like a third-rate medicine for the third world countries. This was the thinking of the developed countries. As a concept, it was radically different from the popular and profitable focus on specialized care. The emphasis on basic care against specialized care created a conflict situation, one that could not be won by the former, that is the basic services. Therefore, health for all by 2000 failed. Nevertheless, during the intervening years, some countries did implement the vision of health for all and primary health care in its letter and spirit. Their experience have demonstrated the effectiveness of this approach, generating renewed interest in primary health care and health for all concept. Therefore, WHO thought that yes, it is possible and we will give another chance for health for all. Now, the imperative for a change, the scope for improving the human condition is therefore great and the action required is urgent. Nations cannot extend their existing health services to cover the entire population at the price they can afford. All of us know what is the cost of healthcare. It is increasing every day. And if we just go on multiplying the existing healthcare system, we will not be able to provide healthcare to all at the cost that the country and the community can afford. So the basic definition of primary healthcare is at the cost the community and country can afford. Therefore, we will have to think in a different way. Health for all, therefore, remains a dream, and it will remain so as long as the dream is formulated in purely technological terms, such as drugs, nurses, vaccines, hospitals, doctors, X-rays, etc. If the dream is to be turned into a reality, existing healthcare strategies will have to be vigorously transformed. First, there are too few resources being invested in the health sector. The public health services of the 67 poorest developing countries spend less than the rich countries spend on tranquilizers. Now mind this, the rich countries spending on tranquilizers more than 67 poorest countries are spending on their public health. Now imagine the total expenditure on health services in the third world, including China, and including the private sector in these countries, is just over half the sum of that spent every year on cigarettes. The world is spending so much on cigarettes, we are not even able to spend half of that on our public health. If this is the situation, then how can you expect health for all? The 2 to 3% of GDP that most developing countries spend on healthcare represents a little as $4 to $6 per capita. If these countries were to increase their health spending in real term by as much as 10% per annum, which itself is difficult, let's assume they will do that. After 10 years, they will still be spending only around $40 per capita, or less than 5% of the amount spent in the USA in 1979-80, not today. So look at the amount that we are spending on public health. That means our priorities are topsy-turvy. We are spending more on defense, we are spending more on so many other things. We will not be able to achieve health for all if we do not give focus on health. Secondly, the few resources that are available are usually spent on tertiary health care, meeting the needs of only 10 to 15% of the population. 85 to 90% of the population is left uncared for. Third, the richer countries are attracting doctors from the poorer ones. Over 3/4 of the world's migrant physicians can be found in just 5 countries: Australia, Canada, Germany, United Kingdom, and the United States. Though it is 8 times more expensive to train a physician than a medical auxiliary, many countries still continue to stress the training of doctors. Even in our country, okay, everybody wants a medical college in every district, okay, but auxiliary nurse midwife training centers are being closed. They are the ones who are going to provide primary health care, not the doctors. Okay, therefore, we must focus on training auxiliary nurse midwives, okay, paramedical workers, which is very much essential for providing the basic health services. According to the WHO itself, 75% of the health problems can be solved at home by non-medical people. Okay, doctors are not required. This is statement from WHO, not my statement. So 75%, but we are focusing only on doctors, producing doctors. That is also quality of doctors. We are not sure. We are suspecting the quality of the doctors because the rapid increase in the number of doctors that we are producing. So therefore, we must change our approach. We require a multi-sectoral approach. Health does not exist in isolation. It is influenced by a complex of environmental, social, and economic factors ultimately related to each other. The health of the poor is largely the result of a combination of unemployment or underemployment, poverty, a low level of education, poor housing, poor sanitation, malnutrition, and lack of the will and initiative to make changes for the better. It would be unrealistic to expect any substantial health improvement in these populations unless these constraints are first removed or alleviated. This we must understand. Thus, health management has to be considered along with such things as producing more or better food, improving irrigation, and marketing products. Even where infant mortality is high, diarrhea and respiratory diseases are rampant, and no organized health services are available, even in such situations, health and disease may come low on the list of priorities. If you ask, even the doctors, if you see, if a doctor is practicing night 11, 11:30, if still 50 patients are there, he will not close the clinic because his priority is, okay, oh, now I am young, I am healthy, I want to earn. He'll continue to practice ignoring his health, his or her health. So health is always neglected, ignored until it is lost. The value of health is realized only when it is lost. So action undertaken outside the health sector can have health effect much greater than those obtained within it. Very, very important. Please note that. I will repeat. Action undertaken outside the health sector can have health effects much greater than those in the health sector. So health must be central to all policies, not only health policy. Look at the agricultural policy. Okay, if you are producing more tobacco and more sugarcane and more cashew nut, areca nuts, and the essential food grains are not available, like pulses and cereals or what millets. Okay, essential things are not available because there is not good price for that. Market is not available. So therefore, this is a cash crop. So we will grow more of tobacco and then say our health is not good because the good food is not available, right? In the market, whatever food is available today, we know the quality of the food, the quality of the, and most of the people who are working, they have no choice but to order food from outside. And we know the impact of eating food which is not prepared at home. So WHO itself now has come out, home cooked food is very, very essential for health. This is not my statement. Okay, it is a statement of WHO. Home cooked food is more important. Please remember that. But to gain such an understanding, yeah, there is another important thing is community involvement. We have to involve the community because health cannot be given. Okay, as I told you, it's an individual responsibility, family responsibility. Therefore, we have to involve the community. The approach that is being adopted to attain health for all is based on the fundamental understanding that it is there where people live and work, that health is made or broken in the families. People must therefore understand what health is all about, and it is the duty of those who know to help others to understand. The doctor's main job is health education. How many doctors are spending their time on educating the patients? They don't have time even to examine the patient quickly. So health education, at least the community medicine and the IMA if they are interested, can take this responsibility and give health education to the people to make them understand what is the important determinant of health and how health can be given to in their own hands. But to gain such an understanding, a minimum level of health is essential. So if a person is very sick, bedridden, okay, no health education will help. He must be healthy to understand and implement what we have told him to do. So this level of health is important. So health and social awareness must go hand in hand, the one leading to the other, and each progressively reinforcing the other. These are the absolute requirements to reach health for all: multi-sectoral approach, community involvement, appropriate health technology, and total health services coverage, total coverage. Okay, all, including the remotest parts of the country and the poorest members of the society, is essential to achieve health for all. Cooperation and not confrontation is very, very important. We are seeing confrontation now, what we are seeing in Rajasthan. Okay, if I say something now, okay, maybe some of you also may be hurt, but the reality is that we must have cooperation from all sectors because they are very, very important determinants of health. The goal of health for all was certainly originated in a climate of political optimism, and that was only a few years ago. At that time, there was still a feeling that in spite of ideological differences, in spite of economic enigmas, somehow our world was muddling its way out of an impasse and was going to substitute cooperation for confrontation. Now we can detect unmistakable signs that it is beginning to change and the world is once again tending to become divided, that we have seen in Ukraine war. Okay, so this confrontation is not going to improve health, but we have to continue to find points of cooperation even in areas of confrontation. All the actors in the existing health drama, the government of the North and the government of the South, their medical, scientific, and industrial establishments, and the international health bureaucracy will have to work hard to reducing the areas of friction and enlarging the areas of cooperation. If we want a system which is accessible to all members of the community, which is concerned with the promotion of health in the whole community, and in which... Can you hear me, please?
Yes, sir.
Yeah, okay. And in which major decisions concerning health are taken and implemented by the community, the doctor will have to become only one component of the team. Okay, he is not the entire team. Okay, the team consists of non-medical actors also, whose every member does what he or she has been trained for, and which is oriented towards identifying and solving the priority health problems of the community. Like the agriculture sector has to produce food which is necessary for health. Okay, the industry should produce the goods which are necessary for health. Pollution should be controlled. So every sector, now engineering sector, like underground drainage system and excreta disposal are not under the control of health sector. So you have to ensure these things to see that health improves. Before that, okay, to achieve the our World Health target, we shall have to work closely with the scientific community. Scientists are becoming concerned about social relevance and social equity. There is growing disillusionment with the research that leads not to action, but further research. There are people interested in doing research, but outcome is nil. It requires further research, further research. Such research is not going to help. You have to do research action-oriented. Whatever research you do, it must be applied to the community to improve the health of the population. The confrontation with the industry are the most difficult to resolve. The pharmaceutical industry, the infant food industry, the tobacco industry, the medical equipment industry, that are all very, very strong. And if you want to bring some reforms with the interest of health for all, then there will be some irritants. So there will be some confrontation. So we have to take this into consideration and motivate them to at least do not do a harm. You can continue your whatever product you are producing, but keep in mind health of the people at the same time. So, for example, drugs. Developing countries found it very difficult to formulate national drug policies because of the resistance of the medical specialists or the general physicians who are often influenced by the international drug industry. Essential drugs, which can cope with the overwhelming majority of the problems, even in relatively sophisticated societies, number around 479. But in a poor country, say like India, 30 well-chosen drugs are enough. Without these drugs, the primary healthcare program cannot work. But just for your information, these drugs are not available in the market. Even if they are available, they are in short supply. Okay, because there is no profit. So these are essential. There has to be some way of producing these drugs first and the remaining drugs later, because the essential drugs are very, very necessary for improving the health of the entire population. We shall undoubtedly have to face many political problems. Some of them will derive from commercial and professional interest, where they are touched, for example, by generation of appropriate technology for health, by adoption of drug policies aimed at providing essential drugs for all the establishing drug industries in developing countries, and by preferential production of vaccines in certain countries. Like when we were producing vaccines for during COVID pandemic, there were heartburns in the West. They wanted to market their vaccines. However, developing country can produce a better vaccine than ours. This is what is the heartburn. So we have to understand that science is not restricted to a particular region, particular caste, particular community, particular people. So it is free for all. So therefore, we have to understand this, and it is very, very essential that all of us have to cooperate. Now, coming to, is health for all a realistic goal? How much will it cost? Let's understand. Okay. Are the costs exorbitant? Recent small-scale studies in developing countries have shown that considerable improvement in the people's health can take place for an extra expenditure as little as 0.5 to 2% of per capita gross national product, okay, or what amounts to few dollars per year per person. Okay, this is not exorbitant. This we can afford. Everybody can afford. Even the poor country can afford. This is, by any standard, a reasonable cost. 100th of what is spent on health by people in many rich countries. So this is easily possible. So cost factor should not hinder governments when they consider their plans for meeting their commitment to the target of health for all. Change is coming, and I am sure we shall succeed. We must succeed. The children of today and those who have not yet been born will never forgive us if we do not succeed. So we have all to commit now that yes, we will all work for health for all. We cannot extend our existing health services to cover the entire population at a price we can afford. We need to make changes in our thinking and actions. Now, what is the change? What is the thing we want? Universal health coverage is one of the important things. Okay, all of you know, I think probably, I'll just cover it briefly. Universal health coverage means that all individuals and communities receive the health services they need without suffering financial hardship. This is very important. There is a report saying that most of the people are pushed into poverty because of their healthcare expenditure. So poverty is one of the important determinants of ill health rather, disease. So we are pushing them into poverty. That means this is a vicious cycle. Okay, they have ill health, they have to spend from their pocket, and they go into poverty, and next generation again becomes unhealthy. Okay, this is a vicious cycle. We have to break this chain. It includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. Please remember, health promotion and prevention are much, much more important than treatment and rehabilitation. But we are spending maximum of our budget, that meager budget. The budget itself is meager, and maximum of that budget is spent on curative aspects. So prevention is only a lip service. It enables everyone to access the services that address the most important causes of disease and death, this prevention and promotion, and ensures that quality of those services is good enough to improve the health of the people who receive them. Protecting people from the financial consequences of paying for health services out of their own pocket reduces the risk that the people will be pushed into poverty because an unexpected illness requires them to use up their life savings, sell assets, or borrow, destroying their future and often those of their children. That happened during COVID. I'll just give some examples for this. We must adopt primary healthcare approach with effective linkages to secondary and tertiary care. This is the only way we can achieve health for all. So for that, what is primary healthcare then? Okay, we have to adopt primary healthcare. Primary healthcare is an essential healthcare that is based on scientifically sound and socially acceptable methods. Both are important. Okay, scientifically sound and socially acceptable methods and technology. This makes universal healthcare accessible to all individuals and families in the community at a cost that they can afford. PHC is a whole of society approach to health that aims to ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs and as early as possible along the continuum from health promotion and disease prevention to treatment, rehabilitation, palliative care, and as close as feasible to people's environment in their homes, okay, at a cost that the country and the community can afford. This is very important. So we must all focus on primary health care. Now, universal health coverage is not new in India. These are some of the milestones. Like in 46, Bohr committee was there, National 83, first national health policy. Now you see we became independent in 1947, but national health policy was formulated only in 1983. See the priority that we have given even in our national development programs. We had five-year programs, but national health policy came only in 1983. Second national health policy came in 2002, NRHM in 2005, Rashtriya Swasthya Bima Yojana in 2008. So there are a list. Okay, so it is not new, but only thing is unless we focus and giving lip service is not going to help. Now, universal health coverage, recent developments, if you can see, PM Jana Arogya Yojana or Ayushman Bharat is one thing. It has got two components, health and wellness centers. They are upgrading the sub-centers, and National Health Protection Scheme, free medical care to poor and vulnerable population. Around 11 crore families are covered. Now we need the whole of population approach. Ma'am, you can see the slide clearly?
Yes, sir.
Yeah, okay. Now this is very important slide. We have to focus on the first one, green one, healthy population, no risk factors, no disease. Who gives attention to these people? I can tell you, I was practicing in Bombay 8 years, and the name of the clinic was Clinic for Healthy People. Okay, have you seen any clinic like this? And I was having a very good practice. Okay, I was giving the skills and knowledge to the people how to not fall ill. Okay, that's very, very important. We must focus on healthy people. It costs very less when compared to treatment of diseases. So focus on most services. I have put it down at the bottom. Most resources have to be spent here. Promote, what do we do? Promote healthy lifestyle, prevent risk factors. This is called as primordial prevention, prevention of disorders and health problems. Okay, next. People have risk factors, but they have not yet developed the disease. So we have to focus next on that. The second chunk of the budget should go on this. Health promotion, screening, action on risk factors, build resilience, maintain healthy lifestyle. See that maintain healthy lifestyle is in every part, everywhere, right from healthy people to the diseased people. So population of the disease, but not aware. This is the third set. Sorry. Early detection, treatment and care, maintain healthy lifestyle, disability limitation and rehabilitation. Now people with the disease, they know they have got the disease. Now we have to treat and care them. Healthy lifestyle again is important here also. Disability limitation and rehabilitation. This is how if we restructure our healthcare system, then I think we will be definitely able to achieve health for all. The role of the family in maternal and child health. Family is central to our healthcare delivery system. If you see, there are certain things which are done exclusively at the family, like early initiation of exclusive breastfeeding, complementary feeding, oral rehydration therapy, hand washing, iron and folic acid tablets, insecticide-treated bed nets, contraceptives. All these are done at the family level. Family can improve these provided they have skills and supplies. Our job is to make them skillful and provide them supplies. Okay, the second one is families take a decision to go to the outreach sessions for such things like vitamin A immunization, so in indoor residual sprays, antenatal care, postnatal care, contraceptive, etc., etc. Again, family. So focus on the family. Even in some tertiary care, for example, so families identify the danger signs. For example, pneumonia. Simple counting the breath sound, respiratory rate. Okay, if it is more than 40, 50, 60, according to different age. Okay, if you educate them, they'll be able to detect early and bring the child to the healthcare delivery system. So that means family has to be focused for our first individual, then the family. Family has to be the focus. Strengthen the family for health for all. A family has to be the center of all our activities. So there is a costing done. How much of Indian families contribute to healthcare at home? It's around 213,000 crores. Out of that, majority, 175,000 crores was contributed by women, and men contribute little, okay, 38,000. And this 213,000 crores, if you compare with the government expenditure of 169,312 crores, both central and state government on health, okay? So that is the key, okay? If you empower women, if you strengthen the families, the healthcare delivery, the burden will be reduced. Now, this is just, you see, there is a, I'm standing by a shore of the swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river, pull him to the shore, and apply artificial respiration. Just when he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying, breathing, and then another yell again and again and again. I am so busy jumping in, pulling them out of the to the shore, applying artificial respiration, that I have no time to see who the hell is upstream pushing them in the river in the first place. This is what is prevention. Okay, if we are not able to prevent the diseases, you will not be able to treat all of them. So therefore, we must focus on prevention. Prevention is definitely more important. Now, multi-sectoral approach, you just look at here, health sector bears the brunt of non-action by other sectors. Now, however much this man struggles, he will not be able to bring the car to normal position because the other sectors are not doing their job. We have a good policy and plan in our country, one of the best rather, but implementation is the problem. So we have to focus on implementation of our policies and plans. Now, coming to public health definition, again, all of you know, but still for the sake of completion, the science and art of preventing disease, prolonging life, and promoting health and efficiency. Each word is important. Please remember, through organized community efforts. This is important. Not organized health systems, organized community efforts for the sanitation of the environment, the control of communicable diseases, the education of the individual in the principles of personal hygiene, the organization of medical and nursing services for early diagnosis and preventive treatment of disease, and the development of social machinery, which will ensure to every individual in the community a standard of living adequate for the maintenance of health. How much time I have, ma'am? If you tell me, I will finish accordingly.
Yes, sir, 15 minutes more, sir. 10,
Yeah, okay,
10 to 15.
Yeah, 10 minutes I'll finish. Yeah, thank you. Now, these subsequent slides are courtesy Dr. Abhay Shukla. He is from Sathi, Pune. Advancing publicness, he says, regarding regulating commercialization, ensuring right to health for all. This is experienced during COVID pandemic and what can be learned from that. and what can be used for health for all. This is what basically his slides. I am using those slides. So here, Paul Farmer says, we thus find ourselves at a crossroads. Healthcare can be considered a commodity to be sold, or it can be considered a basic social right. It cannot comfortably considered both of these at the same time. So we have to decide. We are at the crossroad. Is it a commodity to be sold, or is it a basic social right? Now, there are some heroes and heroines during this pandemic. Just for some examples, Relu Wasave, an Anganwadi worker in Nandurbar in Maharashtra, rode 14 kilometers daily to deliver food and services to Adivasi women and children. She's an Anganwadi worker. See, 14 kilometers daily, okay, forgetting her own family's requirements, ignoring her health needs. So she was doing, she is a real hero. The Dr. Manisha Jadhav, a doctor in Mumbai, continuous dedicated work in public hospital until her death. She died from COVID. Even one day before death, she was working in the hospital serving COVID patients. Jitendra Shinde, a auto rickshaw driver in Kolhapur, transported thousands of COVID patients to hospital free of charge. Mind you, he is not a rich man. He is earning his daily wages, okay, by auto rickshaw, but he has transported thousands of patients free of cost. This is Oxygen Man. Pare Khan spends 1 crore to help provide oxygen to COVID hospitals in Nagpur. There are n number of such examples. What I'm trying to tell you is, this is what is real public health. Okay. In public health, we have got public health system, private healthcare, and the people. We forget the people. People are central to the entire public health system and the private healthcare. If people are not there, what the private healthcare can do and what a public healthcare can do. So we have to understand the importance of people. Now, what we have to do is health solidarity with people, participatory initiatives for co-production of health. Health cannot be produced only by the health system or only by the communities. It is a co-production. We have to involve the community and we have to empower the community. Social accountability of private hospitals. I'm sorry to say this, during COVID, we have seen, I'm not blaming anybody at all, okay, but this is the experience that is well documented. I'll be showing interventionist regulations of private healthcare, modified public-private healthcare arrangements. These are the things which we need to do if we have to go forward in public health. Now, health solidarity means during the COVID epidemic, in hundreds of communities across the rural and urban areas, people came together spontaneously to take action to protect their health and lives, to ensure access to healthcare and essential measures like food grains, to operate local isolation and quarantine centers, to promote epidemic-relevant healthy behaviors, to strengthen protective measures like vaccines, and to demand right to life-saving health services. This is people themselves. They did not come from top, no directive from the government, no from the health director. This is spontaneously from the people. Participatory initiative for co-production of health. Health cannot be produced only by health sector. If the individual decides to smoke, drink, okay, have multiple sexual partners, what a health system can do to improve the health. So it has to be the individual community with the healthcare delivery system. During the COVID epidemic, hyper-centralized government actions were taken at the national level. Say, for example, declaring suddenly lockdown. Okay, the abrupt sweeping lockdown was an example. In parallel, many spontaneous local initiatives sprang up, independent of state directives, bringing together local leaders, frontline health workers, grassroots activists, community groups, and civil society organizations, occupying the interstices emerging during the crisis. These participatory efforts like public-public partnership, I don't call this as public-private, it is public-public partnership, provided much needed support to patients, migrant workers, and various groups affected during the COVID situation. The co-production of health appeared spontaneously on a large scale during COVID, showing a new horizon of what is possible through people's collective action, collaborating with frontline public services. Civil society run up help desk in public hospitals. See, all hospitals were converted into COVID hospitals. Where do people go for delivery? Where do people go for cardiac problems? Where do people go for cancer? Okay. These diseases do not disappear just because COVID is there. So people were lost. So they were helped us in public hospitals, and they were directed where to go, when to go, and what services are available. So this is again public-public partnership. What is co-production of healthcare and health? The co-production of health approach originated in the clinical setting, advocating for partnership between health professionals and patients to improve health outcomes. The co-production approach recognizes that healthcare cannot be optimally produced either by health services alone or by communities acting on their own. Only equitable and democratic collaboration involving public health systems, frontline workers, and communities can ensure optimum healthcare and people's health. This involves configuring a major equity-oriented shift in power relation between health systems and the people. Co-production of health services emphasizes the essential role of the state to provide health services. We cannot abdicate the state, okay? But people must be involved. Ensuring social accountability of private hospitals. I'll skip this. Now, this is just an example. The government had fixed the rates for hospitals. The rate was fixed at 7,779. That means 7,800, you can say. But the average charges here is shown around 33,000 to 40,000 plus. So actual per day hospitalization costs were 4.3 to 4.9 times higher. I'm not talking about every hospital, but these are studies done to illustrate some of the hardships that people faced than expected. Just 5 days of hospitalization wiped out the entire annual income of a person earning average income. That means we are pushing them into poverty, which is an important determinant of ill health. So these are interventionist regulations of private healthcare. Again, this is a touchy subject. I will not go into that. Market reshaping public-private healthcare. Again, we will skip this. Now, continuing the approach of expanding publicness, checking commercialization beyond COVID. Commercialization is not done by all hospitals. There are very, very good examples of private hospitals and private practitioners doing a wonderful job during the COVID. But some corporate hospitals examples were quoted. So corporatization even is harmful for private practice and private hospitals. So we have to keep that in mind. Yes, there is a public patient's right charter, which is a law, and every hospital is supposed to display this patient's rights charter. Okay, now this is what, concluding 2 slides. Indian healthcare system is dominated by profit-driven, unregulated private healthcare. Okay, private logic versus social logic in community. Now, yeah, this is one more thing. We say that India is a poor country, but there are billionaires, dollar billionaires, not rupee billionaires. And you see, maximum billionaires come from healthcare. Okay, the harvest from COVID, net worth of India's healthcare billionaires is around 9.37 trillion. We are talking about only billionaires. We're not talking about any doctors, any practitioners. Okay, no nursing homes. Don't misunderstand me. These are the billionaires. Okay, and India's total public health spending from states and central government is 2.42 trillion. That is much, much less than the worth of these billionaires. Okay, so what I mean to say is, though we are a poor country, there is enough resource available also. Now you see, if 2.42 trillion is the government budget and 9.37 trillion is available only with these 232 people, okay, we can definitely redistribute some of the resources if it is possible, or if they are willing, and then we can have a public health system which is much, much better. Now you see here a bigger shark eating a smaller shark, eating a smaller shark, eating a smaller fish. Like private practice, private hospitals, private nursing homes are all going to be closed if we have got complete privatization and corporatization of the healthcare services in the country. So that is one warning I am little apprehensive about. So Yes, thank you very much for your patient hearing. Smile a while, and while you smile, others will smile. Soon there will be miles and miles of smile. Life is worthwhile when you smile. Okay, that is what is all about public health. Thank you very much. Over to Dr. Geeta.
Dr. Pankaj sir, you want to say anything?
Yes, very much in depth. A topic discussed by Dr. Anna Rao, and the emphasis that he lays on prevention is the key to health for all. I just hope the authorities there do listen to him. The focus is basically definitely on curative, and the prevention needs to be taken with very strong conviction by the government. And I hope the Niti Aayog people also listen to this. Thank you very much, Dr. Kulkarni. You did a wonderful job. Thank you very much.
Thank you, sir. Thank you very much.
Any questions?
Yeah, any questions? I would like to take those questions.
Sir, you mentioned about the board to be published in the hospital in private setup, but
Yeah.
that slide was.
You want that slide? Okay, because
yes,
there is a charter. There are 20 rights of the patient, and it is made compulsory by the government. Every hospital has to put that. Okay, I'll just put that slide. I'll just see if it is coming.
Sir, I'll share it later, sir, to madam.
Yeah, okay.
I will share it to Veena madam. Yes.
Yeah, okay,
Yes.
right. Yeah, any question? That charter is available even on the internet. You can just Google, okay, patient side charter, you will get that.
Okay, sir. Thank you.
Namaste, sir. It was very nice talk, sir.
Thank you, Ravikant. Nice seeing you after a long time.
Yeah, sir. Very long time.
Yeah.
Good evening, sir. A wonderful talk. As you suggested, I think a holistic approach is required, not only taking into health, but also probably other social factors like maybe education, which is there, basic sanitation, housing. All these will actually be acting as a preventive measure as well. Literacy will help them to adopt healthy behaviors, and then it'll take again. Wonderful to hear your lecture. Congratulations, sir.
It is said by WHO that if two things are done in India, 50% of the health problems will disappear. These two things are safe water supply and safe disposal of excreta. Okay, only if these two things are done, but unfortunately they are beyond the control of the health system. Okay, I can't do safe water supply and safe excreta disposal. Okay, if this is done, 50% of all health problems will disappear. Okay, this is the problem. The government has to focus on the right priorities.
Good evening, sir. Dr. Padma Prakash.
Yeah, good evening.
You have covered all the aspects, sir. So people like you should be the personal secretaries to the health ministers, where they can implement the things, because doctors, we do service to the society. When coming to the implementation and reaching to the people, so I think that is a failure. But still, compared to 1990s, whether it's a neonatal mortality rate or a maternal mortality rate or the infant mortality rate, I think now it is 25 or 27. I don't remember, sir, neonatal mortality rate. So we have we have improved a lot. Because combined effort from the availability of the hospitals, whether it is a corporate hospital or a primary health center, which is accessible to the people. So in that way, we have improved a lot, India compared to other countries. But still, a lot of coming up, so whether it's the central or the state government, lot of projects, and people are being getting utilized those projects. That's what you got a lot depth of knowledge. That's what I was thinking, starting from as a responsible citizen, as a responsible doctor. You have covered even the projects, what has to be done from the government as from the government side. So we are expecting your sincere and your ideas to be like, to reach the policy makers. That is my humble, that's what I am feeling. So thank you so much, sir, for your, you have thrown a light on every aspect.
Thank you. I just want to inform all of you that I am elected as a national president of our association, and I have a plan. Okay, I am just the president-elect. Next 1st April to 2024, I'll be taking over as a national president, and we have a plan to reach the ministry, and not only the health ministry, all the ministries, because agriculture ministry, industrial ministry, okay, every ministry has to take their role to improve the health. The health has to be central to all policies, not health policy. Okay, not only health policy. So this is my plan. Hope the people listen to the advice given by the association. Okay, as a president, I have a plan. Let's hope so. It will work.
Congratulations.
Sir. Hello.
Yes.
It is a wonderful lecture, sir. You have given for so much.
Your voice is breaking.
Suresh sir.
हाँ sir. हाँ madam.
ಈಗ ಕೇಳ್ತಾ ಉಂಟು ಹಾ ಸರ್.
Good evening. It was a wonderful lecture, and I want to ask what how can
sir, we are not able to hear you, sir.
Ask him to type, ma'am. Ask him to type the question. If you have.
Our honorary secretary of AMS, Dr. Suresh, sir.
Sir,
you can just your video you can off and talk, sir. Off your video, sir. Sometimes internet connectivity may be poor.
Hello.
Yes, sir. Yes, sir. Please talk, sir.
Based upon today's lecture, what we are going to conclude that do from our IMA KSP, shall we give some any recommendation to government regarding the for all
Geeta ma'am, can you convey? I can't hear what he is saying. I can't hear.
No, actually, even for me, sir, it's not audible properly.
Yeah. So because I can't respond, I'm not able to understand the question only.
Okay, Rajendra Prasad.
I think he's saying that
unmute, sir.
from IMA KSB we can give the recommendations.
Yeah, sure.
From IMA KSB we can give the recommendations. What and all you said. I think that's what I could hear, sir.
Sure. If you need my help also, okay, while formulating the recommendations, okay, I'll be there to help you if you want.
Rajendra Prasad, sir, you want to talk anything?
Hello, madam. My question is,
yes,
is it recommended to have a medical college in every district? That is one. And should every hospital have ICU? That is what is it? That we see a difference between the felt need and the real need. That is what I feel. I want to know what the expert says.
Sir, if you ask me, okay, there is no need for medical college in each district before we have A&M institute in each district. Okay, if you are capable of starting the A&M institutes first, then you still have the resources, you can go for the medical college. We are having a topsy-turvy priorities, lopsided priorities. First, we require to provide what we have understood from today's talk is, see, primary health care is delivered by auxiliary nurse midwife and the paramedical workers. Okay, doctor is not required for so many things where the people have to be empowered. The skill and knowledge is enough to take care of their own health 75% of the cases. Okay, so therefore it is not essential, but these are all political decisions. I and you cannot decide, and or even if you say, nobody will listen to you. So, but scientifically speaking, we require more number of paramedical workers than the doctors at present. This is only from public health point of view. Okay, I am talking about health for all. For achieving health for all, this is the need.
Thank you, sir. Yes. So I
Any
think after this exhaustive lecture of Dr. Kulkarni sir, now I think we come to the end of the session. I request our Honorary Secretary of IMA AMS Karnataka State Branch, Dr. Suresh Kagalkar, sir, to propose the vote of thanks. Hello.
Hello.
Yes, sir.
Good evening, everyone. Now we are giving a vote of thanks. First of all, I should give thanks to the Dr. Anna Kulkarni sir, who has given a wonderful and it is a very exhaustive and it was a knowledgeable lecture which we got. So thank you, sir. Thank you, Anna Kulkarni sir, for giving a wonderful lecture, sir.
Thank you.
And we will include the many of the health tips in our coming IMA, whatever recommendation we are giving to the government. That's what I want to convey the message, that how best we can convey the message through our lecture to the government regarding the surgery, medicine, and obstetric gynecology, and different specialties. Because one person, if as a public person wants to know regarding the health, how he can get the knowledge or skill by the different specialty. That's what my message was there. So I also understood regarding your lecture, sir. Thank you very much, sir, for accepting our invitation from the IMA ASP, sir. And I should give thanks to the our IMA ASP, the president, respected president, Dr. Shivkumar Lakro, sir, for giving a opportunity. Last time it was a 2 days. We were in confusion whether to conduct a study or not. So, we and also it was a wonderful lecture. Thank you very much, sir. So, to the our respected Vice President, Madam Rajeshwari Annamal, Madam, who were there, and all the Madam presence was there, and wonderful time, Madam, for joining. And also, I must say thank you to the Masood Karidunu sir, who was our ex-president of MAKSB, for joining wonderful lecture. And thanks to all the respected members, and also thanks to the Dr. Veena Madam, Madam, Padma Prakash Madam, and all the members who have joined. And it was a wonderful lecture. And on the day of World Health Day, and we concluded that this was successful. And we'll meet in the next month in the similar day and with a similar time with a different topic. And once again, thank you for everybody. And we'll meet you next week, sir. Thank you.
Yes. Thank you, Suresh, sir. Yes.
Okay. Thank you.
Yes.
Thank
So
you,
once
madam.
again,
Thank you,
yes, sir.
everyone.
So once again, I would like to thank Dr. Anarao Kulkarni sir and Dr. Pankaj Mutneja sir, Dr. Srirang sir of IMA AMS headquarters who were there with us for this webinar. We wholeheartedly thank you. We thank Lakkol sir and all our IMA KSB team. Thank you one and all.
Thank you. Thank you. Good night.
Thank you. Thank you one and all.
Good night, sir.
Thank you, everyone. Thank you so
Thank
much.
you.
Senior doctors.
Good night, madam. Good night.